Good evening, everyone. This is Meldita. I'm back here at my YouTube channel, Meldita's Info Corner. And my Facebook is johnregacho@yahoo.ca. Okay, so the WINTER'S ECG or pattern. Well, this is a developing transmural myocardial infarction preceded by upsloping ST depression and peak T wave. Okay, so anyway, I got this, this reference here. I got these three types of the winter sign. So let's make it bigger. So here we go. So we have here type 1, type 2, and type 3. So type 1. So this is the picture. So QRS wave, they don't happen all the time as QRS waves. Sometimes you have a QRS that is RS wave, QR, RS. Okay. So type 1. So we have a J point that is depressed. ST upsloping. It starts after horizontal ST depression. Okay, let's take a look at the picture. So here, we have here an RS. J point is actually the meeting point between the end part of the QRS and the beginning of the ST segment. Okay, so you see that one? Okay, so they meet at the J point. So we have here ST depression, and the tail part or the end part of this ST segment actually went upsloping, and we have a peak T wave. Okay. So the second type here, we have a J point that is depressed, but if I look at this drawing, I should say any ST segment that went below the isoelectric line, I consider that ST depression. So there's a little bit of downsloping ST depression, and again, the tail part of the ST segment is being pulled up, so we have peak T wave. Okay. In type 3, we have here no ST depression, just hyperacute T waves. Okay. So in here, you see that we have an ST segment that is almost baseline. That's why they said there's no ST depression, but we have hyperacute T waves. So all their T waves are hyperacute. The only differences here, we have type 1, you have ST depression, horizontal, upsloping. The second one, yes, you have a slight ST, downsloping ST depression, and the tail part of the ST segment is being pulled up, having peak T wave. And the third one, there's no ST depression at all. Okay, so the WINTER'S has no ST elevation. It has peak T waves. The duration of the WINTER'S is short. That's why you don't catch this. Right away, what you see is a STEMI. Okay, so why? They said there are some hypotheses that suggest or talk about what's going on with the WINTER'S, what causes the WINTER'S ECG like this. Okay, this is what they say. This is the reference. Okay, so here, there's a lack of activation of the sarcoplasmic sensitive potassium adenosine triphosphate channels in ischemic ATP depleted cardiomyocytes. Of course, if you have a black flow, then there will be deficient blood supply, and that blood supply, it has oxygen. So what's happened here, we're going to go anaerobic metabolism. Next, there's an anatomical variant Purkinje fibers which causes delay in endocardial conduction. That is our reference. Okay. So what causes the WINTER'S ECG then? What? We talk about occlusion of the coronary artery or coronary artery branches. So I made this drawing. So I have here the aorta, the RCA, left main that divides into two, LAD, and the circ. D1 as the branch of LAD and so on. OM as a branch of circ and so on. But I just mentioned the main ones, okay, because that will be touched on this topic. Okay, so the most common cause of the WINTER'S ECG is a blockage in the proximal LAD. So this is the LAD. So when this is blocked, the proximal part of the LAD, there's a chance to cause the WINTER'S ECG in less than 2% in all acute anterior myocardial infarctions. So the incidence of the WINTER'S with blockage in the proximal LAD is less than 2% in all acute anterior myocardial infarction. Okay, but other arteries can be also causing the WINTER'S. For example, if we have a blockage in the left main, RCA, the circ, they too can cause, but the most common of them all is the LAD occlusion in the proximal area. Okay, but there are other problems that can also cause de Winter's. So we have here disease processes like microvascular dysfunction, and we have also myocarditis. So this is my reference. All of this has references. Okay. So I have a drawing here of the heart. So we have here a heart muscle, and the innermost part is the inner layer, is the innermost layer is endocardium, myocardium, which is the thickest layer, and epicardium. Okay. So the inner endocardium, the most, okay, that is the largest layer, myocardium, that's the muscle, and epicardium, that's the covering. Okay, so I got this reference. We admitted before a patient with de Winter's, but it was a very extreme, it was a very busy night. I didn't have a chance, but the doctor showed us de Winter's, and I said, oh, I've never seen that before, so I'm interested. But anyway, too late. I didn't have a chance to go over it. But anyway, I'm presenting it now, so I got this reference and got these ECGs. Okay, this is the reference here. Okay, so a patient came in, and this is the precordial leads with upsloping STs here. So this one looks like number 2. Okay, but the most common one is type 1. But our example here is type 2. Okay, so you have here a slight, actually this is a ST depression downsloping and pulling upward, becoming upsloping. Okay, so anyway, so the question is why we have these big T's and everything. So I went over some reading materials there. Okay, now this is what one references would say. We have here a subendocardial myocardial infarction or ischemia or myocardial infarction that went and expanded to the beginning or getting into or penetrating the myocardial area. Okay, so you're going probably mid part, or you're just getting, so from the innermost, you start going up now to the myocardium, but partially. And that explains probably all these peaked T waves in here. Okay, and then because the duration is short and nothing has been done, because nobody knows, or maybe a doctor knows, but the doctor is not the one that you're speaking with. So let's say it was brought late in the hospital and still having that severe chest pain. And this is what you see. We have now ST elevation in those leads. So this one, and then suddenly they went STEMI because they're saying with the duration so short, it will end up to STEMI. So from the Winter's, that penetrated until the mid-myocardium or partially to the myocardium, to the full myocardium muscle, now they will have a STEMI. So the bottom line is they found that there's a blockage in the proximal left anterior descending artery. So they put a stent, then the problem is solved. Okay, so it's proven that we have a blockage in the LAD, and that has been stented, and the problem is resolved. So that's good. Okay, so duration is short. It starts creeping to our myocardium, to the full myocardium if not done right away, and that's it. So the doctors, whenever they see the Winter's, they go right away and bring the patient to the cath lab and look into it, and that's what they're gonna see, a blocked proximal LAD. So another thing too, what if they brought the patient to the cath lab and they found nothing? Of course, we have disease processes that can also cause de Winter's. We have microvascular dysfunction and we have myocarditis. So here, these diseases processes, okay, like microvascular dysfunction and myocarditis, they too can cause de Winter's ECG. That's why the determining point here is bringing the patient to the cath lab. Okay, so when you see de Winter's right away, the patient has to be prepared and brought to the cath lab because the duration of de Winter's is very short. Okay,